Hello, my name is Kevin Nugent, and on my own behalf, and on behalf of NBO trainers around the world, I'd like to welcome you to this program introducing the NBO, the Newborn Behavioural Observation System. Now, if you've never worked with infants or babies this young, you're about to embark on a remarkable journey that will deepen your professional life and we believe will change and enrich your personal life besides. But if you do work with newborn infants and families, either in a hospital or clinic or as a home visitor, then the NBO will add to your work with parents by bringing the baby into focus. The NBO is a clinical tool that can be used to strengthen the relationship between babies and their parents from birth up to the 3rd month of life. It's a strength-based approach designed to capture the full richness of the baby's behavioural repertoire. It describes the baby's capacities in such a way that parents can begin to see the baby as a person. And in this program, we will introduce the history, the background, the contents, the uses, and the evidence supporting its value as a clinical tool. But first, let us hear from Dr. Susan Nicolson, a colleague and NBO trainer at the Royal Women's Hospital in Melbourne, Australia.
The Newborn Behavioural Observations system is a very simple but really quite powerful way for clinicians from a whole array of different backgrounds and workplace settings to help parents with their very new baby and up to the age of 3 months to get to know their baby well. We're talking about us clinicians helping parents really start to notice the nuances of baby behaviour. The slight shifts in the baby's state from, say, deep sleep to light sleep to doziness to quiet alert, fussiness and active crying, helping them read the baby's state and be able to appropriately respond in a way that will build the parent's confidence. It'll also likely build the relationship between you as a clinician and the family, and that's always important when we're working with vulnerable families. But I would argue that the NBO is useful for just ordinary everyday families. I think it's very unlikely that there will be a family who would get nothing out of spending 15 minutes with you as a clinician, just with you together, observing their baby and directly interacting with the baby as a person, responding to what the baby's saying in the moment and learning what makes a difference to their baby if they're upset, what helps them settle if they've been unsettled or fussy, and what gives their baby some pleasure or helps their baby to stay calm, then to open their eyes and be ready to be curious about their social world. I think that's the real reward of the Newborn Behavioural Observation System.
Now I'd like to invite you to take a look at our training program and the steps necessary to become certified in the NBO. First, I'll describe the NBO, its contents, before going on to talk about the steps. And then I'll take a look back at the NBO, where it came from, its origins, its relationship to the NBAS. And we'll end this introductory session by focusing on my colleague Yvette Blanchard using the NBO in a home visit with families. Well, as you saw from the film with Dr. Nicolson, the NBO is really an interactive relationship building tool, above all designed to strengthen the relationship between parents and babies, beginning in the newborn period and up to the first 3 months of life. Above all, it's strength-based and really moving away from the pathology or the what's wrong, sort of the deficit-based model, looking at what the baby really brings to the equation, identifying the baby's strengths, but also acknowledging the challenges the baby faces as we come up with a picture of the baby as an individual. So it really It's used to support parents at the time when they're really growing to their own skins as parents, to support them and giving them the sort of confidence they feel when they feel they're getting to know their baby. So the NBO describes the baby in such a way that the parents can begin to see their baby as an individual, as a person, with his own needs, expectations, even hopes and dreams, one might say. And by better appreciating the baby's unique competencies and vulnerabilities. But to learn to understand the baby in such a way that it can meet the baby's unique developmental needs, his, her own unique needs. So here are the objectives. We'd like you to know how to identify, describe, and make sense of baby's behavior in the context of the NBO. We'd like you to be able to administer and record the NBO and administer it in a way that's, if you like, organic to you, that's part of your natural behavioral repertoire, so to speak, so that it really fits in a way that conveys your natural sensitivity to parents and families. So it should be that flexible, if you will. Thirdly, we want you to really understand that this is not an assessment per se, but really it's about building relationship. It's about collaborating with parents, partnering with parents. And really important is building the relationship with the parents and helping the parents build the relationship with their baby. And finally, using it in a way that's developmentally sound, but also culturally sensitive. Here's an overview of these 7 steps. After this orientation, you will come to the 2 training days. That's really face-to-face, where you really get, I think, a real sense of what the NBO is in great depth. But along with that, we'd like you to study the handbook and the recording forms, which you'll get on the day of the training. And then, after you leave the 2 days, go back to your own practice and practice until you feel really comfortable with the administration. We suggest at least 5, with at least 5 babies and families, but it may take more than that. It took me many more. If you're experienced with babies, of course, that's you have a step up. But if it's new, you want to really take time to be able to observe, feel comfortable handling the baby, because the babies will pick up on your anxiety. So developing that kind of ease in handling, so it's really can be administered fluidly. And it appears not as a series of maneuvers per se, but the baby is revealed. So the parents don't see a step-by-step progression, they see their baby in all his or her richness. But after the 5 practice sessions, we'd like you to go on to do 5 more formal sessions, where you record and write the summaries. And during that time, by the way, you avail of our online telementoring. So we have a scheduled first telementoring session 1 month after the training, and then another 3 days after. These are allowing you and your colleagues at training to talk to us about what issues you're facing, so we can discuss the cases you have, but in a way we want you to really feel absolutely at ease and know this approach inside out, outside in. Finally, when you feel ready, you return the completed parent questionnaires and the 5 NBO recording forms, certainly within 6 months of the training, of the face-to-face 2 training days. If you need continuing education credits, they can apply to the University of Massachusetts at Amherst, and they should be submitted between 3 and 4 months after the training. And when it's all done, you get a certificate of completion signed by the trainers, and the CUs are awarded. So that's the training overview. Just to remind you again, focus very much on the baby as an individual. Focus, secondly, on building the relationship. And thirdly, focus on your relationship with the family as well. Here it is, I suppose, one of the iconic pictures, the clinician in the hospital with the 2-day-old baby, with the mom and the dad. And you can see, once again, the shared focus on the baby. The question, who is this little boy? What do you want to tell us? Because he's the one who will tell us how to parent him. There's no sort of parenting philosophy built in here. The only philosophy comes from the baby. So to give you an overview of the history and the background of this and how it's used, let me invite you to look back. As we said, the baby is really at the center. The focus is frankly on the baby's behavior and the baby's cues as a way into the baby's mental state. In the NBO approach, the baby's behavior is seen as the port of entry. This is the word of Daniel Stern. So when you're with a family, the baby is our ally, he's the catalyst, he's the focus of all our attention. So we gather around with the baby at the center, both in the way you sit with parents, also both psychologically and physically speaking, the baby is the center of this whole endeavor. Because behavior is the window into the baby's mind, the baby's brain, and the baby's heart. And nothing can substitute for having a deep understanding of the rich behavioral agenda of the baby, what's happening in the baby. So it's up to us and the parents to be curious about, to wonder about, to try to discover what does this little baby want, what does he need, how can we support him. So for you as a clinician, you too will be going through the whole process of being reflective about what you see. And you'll get the capacity, develop the capacity to really mentalize, to see into this little baby's mind, to be able to read the baby's cues, and then support parents in the same endeavor. So now let's look back to see what we've learned and where we've come from, and really at how science has understood newborns beginning the last century. You probably have heard this great iconic phrase. It's almost in every textbook you'll find the words of the great pioneer in infant studies, William James. But for him, the world of the infant was considered a buzzing, blooming confusion. And even up to the middle of the last century, the newborn was seen as a subcortical organism. You couldn't see or hear it, could only respond with innate reflexive responses. Let's take a look. Yes, here's a little baby on the left at the moment of birth. One could imagine the noises, the lights. It surely must be a buzzing, blooming confusion for that little baby. But look at it 30 minutes later on, we had underestimated how babies could parse, understand, organize this environment. And in this case, being so organized, he opens his eyes and begins to look and search for his mother's face. So, we now know Robert Fence first showed that babies could in fact see. Not only see, but really had clear-cut visual preferences. In this case, you can see on the bottom, prefer the checkerboard over the more bland grey display on the right. So they were drawn to interesting, if you like, stimuli. But I think what Fence really showed us that's important for us to realize is that babies are not just, they can see, yes, but they have preferences about what they want to see. They're making choices about what to see. So maybe he's looking around, he's not looking vaguely, he's searching for something to become engaged in. But of course, if you look at preferences, yes, the baby prefers by far the mother's voice, as if there's a biological predisposition to search for and engage the mother. And it's the baby who often initiates this whole visual interaction. Yes, we discovered two babies could hear. For so long we thought babies couldn't really hear. The ears were all stuffed up, so to speak, and they couldn't really hear. But Michael Wertheimer showed that babies could orient to a sound as early as 10 minutes of age. Now we know they can locate a sound. Look at the second bullet there. It's a very interesting one. Baby's hearing is so fine-tuned that the baby can detect a missing beat and a musical pattern. Pull back the last note and the baby is startled. He already anticipates a rhythm, a pattern. The baby is so tuned in to the very rhythmicity, the musicality of sound, as researcher Colin DeVarthen has spent a lifetime focusing on this, the conversations of newborns, you might say, because babies can certainly differentiate one person's voice from another. What do they prefer to listen to? Yes, of course, it's the mother's, the father's voice. You will see later in this lovely picture on the right, because I was there on that day, it was my hand holding the baby, and the mom called the baby's name. And the baby turned and looked at her. And look at the mother's expression. He knows me. Of course, we know about newborn smell and touch. The NBO, we don't look at this per se. Nevertheless, we have to acknowledge the importance of smell and touch in the baby's life. when the baby is in the mother's arms. The baby can locate the smell. And clearly we know babies prefer certain smells to others. And close physical contact, such as in breastfeeding and the hours after birth, they allow the baby and mother to recognize each other through smell as well as through touch. Taste, we know babies have already sort of a well-developed sense of taste. And in one study by Hernandez-Ria from Tiffany Field's group showed babies could differentiate between a smooth and nubbly textured nipples. So certainly the sense of taste is also well developed. And not only that, imitation. When Andrew Melsoff and Keith Moore reported way back in the 80s that babies could imitate, people doubted its veracity. Yet you can see the pictures. These are just 42-minute-old babies, newborn babies in the first few days of life, could imitate the facial expressions, the tongue thrusting of people like Melsoff and Moore. Many people, like myself, were doubting Thomases and wondered, well, what's the value in putting out your tongue at a baby? But actually what it reveals is the baby's capacity for observation, not to mention reproducing the actual behavior. But the baby is such a keen observer, he can pick up these different expressions in the adult's face. So certain imitation is, if you like, the prologue to interaction. And often with many dads and moms, it can be really the beginning of playful face-to-face interactions. So we've seen babies can hear, they can see, well-developed sense of taste, touch, have the capacity to imitate. But Peter Wolf took it all a step further. He actually spent his time as a psychiatrist observing babies at the old Boston Lying-in Hospital and discovered that babies had very well organized patterns of behavior. It wasn't just a buzzing, blooming, random behaviors. There were actually patterns that were observable. So when babies are in deep sleep, they stayed in that deep sleep. There was no rapid eye movement. They were just, the house could fall, so to speak, and they would remain asleep. Then there was that light REM sleep. And you knew that by the baby's flickering of the eyelids. Then there was a drowsiness state where the babies were, if you like, transitioning between sleep and wake. It was that sort of like the yellow light in a traffic light. And then fourth, you have this quiet alert state. The baby is, like the baby in this picture here, is looking at ease, motorically relaxed, and is ready to look around and perhaps search for the human face. Then some babies can be in an active alert state. They're moving about and maybe the mom or dad might have to cuddle them, just tuck them in, and then they can become organized again. And finally, the baby is in a crying state, where there's a full-blown cry, and the baby is saying, I'm not happy, I need support. Let's take a look at these states right now.
Infants have 6 states of consciousness. State 1 is a deep sleep state. Characteristics include eyes fully closed, no eye movements under closed eyelids, regular respiration, no spontaneous activity except for startles and sudden jerky movements. State 2 is a light sleep state. These behaviors are common in State 2. The eyes are closed, but may briefly open from time to time. There's rapid eye movement under closed eyelids. Activity is minimal. There are random movements, and there is sucking on and off. State 3 is the drowsy state, when the baby transitions from sleep to wake. Indicators of State 3 include semi-dozing, heavy eyelids, variable activity, and smooth movements. State 4 is the quiet alert state. An infant in State 4 shows a bright-eyed look, an invested focus on a stimulus, and minimal motor activity. A baby in State 5 is active and often fussy. Characteristics of State 5 include open eyes, brief periods of fussiness, high motor activity, thrusting movements, and may have spontaneous startles. Finally, a baby in State 6 is not happy. Signs of State 6 include an intense cry and high motor activity.
Now, Barry Breslin saw all this way back in the 70s, so yes, babies can do all these things, but I think he was a practicing pediatrician. There's more to a baby than all these if you like, discrete behaviors. Every baby I see, he said, is not only competent, but is a fully responsive human being, a child with his own temperament, style, or personality. So Barry was the first one, not only discovered infancy, he was really the first person to say there's a huge range of individual differences in babies. And it's so helpful for us as we work with parents to focus on the individual style of this little baby. Here I am with Barry Brazelton a long time ago when we were just young, realizing under Barry's mentorship, showing that babies are, if you like, have an innate motivation to engage. They want to be engaged from the very beginning. Here's a one-day-old baby turning to Barry's voice. Again, we saw that this was, the baby was capable of interaction from the very beginning. Let's take a look at this old film, beginning a black and white film, showed Barry beginning way back in the 70s, interacting with a baby.
I'd like to know whether when he turns to my voice, he will also begin to search for my face. Can you turn over here if I talk to you? Can you turn over here if I talk to you? Can you turn over here if I talk to you?
The NBAS was developed half a century ago by American paediatrician Dr. T. Barry Brazelton. His formula was the first to go beyond testing for abnormalities by bringing out the best in the baby, the infant's strengths as well as its challenges.
Walking, he shows a typical response as I press the soles of his feet onto the bed.
The model met with skepticism early on. It took more than 2 decades before his work was published and the medical community slowly began to accept his then revolutionary ideas. But Brazelton and his colleagues persevered. Now in his 80s, the pioneer paediatrician stays close to the cause. His colleague of many years, Kevin Nugent, sums up the scale this way.
It doesn't assess in that classic traditional term at all. It really just reveals a portrait of the baby that tells us, the caregiver, the parent, who he or she is. And if they could articulate it, they would say, this is what I can do.
A baby's behavior is his language. And if I had one thing I'd like to bring about by sharing a baby with a new parent, it's that you can trust that language.
So the newborn behavioral assessment scale, as you can see, that really made a huge contribution to our understanding of the baby as competent, as organized, as social, and above all, the baby as an individual with his or her own unique set of dispositions and sensibilities. But as I used the NBS over the years, I could see that parents were intrigued. So I began to really think about using the NBAS as a teaching tool for parents. And indeed, this is what we did for a long time. But over time, we realized that we did something more, if you like, relational, something more flexible, so that all of you who work, whether it's in a hospital setting or a clinic setting or as a home visitor, could use this flexibly with families in a way that responded to the needs of the baby and the family. So it should be flexible and interactive, but still as effective in working with families. And that's why we began to develop the Newborn Behavioral Observation System. Here is the NBAS, a beautiful picture of a 2-day-old baby tracking the red ball. Look at the engagement in the ball. That baby is absolutely, totally focused. Here is the same 1-month-old baby in this case, because the home visit, but this is the NBO. It's now shifted to a family context. The mother is at the center, the father, by the way, is taking the picture, the clinician, the home visitor, is on the left, holding the ball, and there's the big sister engaged. So it's really a family-centered approach. And here is the little girl at the end of it. So this moment may well have been very important in her understanding of her little brother. So here's the NBO. It's based on over 30 years of research and clinical work with newborns. But the shift is from assessment, which the NBAS does, to relationship building, observation. We're not here to assess your baby. We're here to observe your baby with you. So the invitation is not to say, I'm going to examine your baby. Rather, the invitation is posed in this way. Let's look at your baby together. See what he can tell us about himself. Let's see what we can learn from your baby. So in the NBO, the baby is the teacher. we have to suspend, pull back from our role as teachers, or it's a non-didactic, really respectful of the baby and respectful of the parents. We hope it can easily be integrated into everyday clinical practice. Once again, focus on individuality, focus on the relationship, and focus on your relationship with the family too. So it's above all a developmental or relationship-based care model, strength-based, and primarily based on the principle that the quality of the relationship in the first months of life will play a huge role in the development of the parent-child relationship over the course of time. In many ways, this really, using a story metaphor, the NBO gives the baby a voice. The NBO gives babies a voice everywhere. Make sure they're recognized when we're with the family, that we take time out to say, who is this little boy? Who is this little girl? What does she need? What does she want? So as I said, the baby is certainly, not only do we have her voice there, but she is the teacher. Secondly, the NBO session gives parents a voice. We want to hear the family story. What do you hope for? What is your concern? What is your hope? What are your expectations? And bring these two voices together through the NBO. Through, you will see, as you're going to see more, there are about these 18 items. And firstly, we look at the baby habituation. You can see down on the left-hand side there, the baby responded to rattle or a light. And this is really looking at the baby's, if you like, sleep protection. What does the baby do when he's asleep? What can we really learn from the sleeping baby? So if the baby is asleep, there's so much to learn. And that's why we do the habituation at the beginning. Throughout, we look at the baby's tone, activity level, how much support the baby needs, how much scaffolding the baby needs, how much the baby just needs to be cuddled. We look at the baby's reflexes, particularly with a view to how they influence the maternal and paternal behavior, rooting in terms of feeding, sucking, hand grasp, all important in terms of relationship building. We'll also look at all the areas of the baby's response to, if you like, face and voice, to the red ball, the rattle. So it captures these. But also it captures the baby's crying and consolability. And we acknowledge, we welcome a cry in the NBO setting because crying is part of life. One of the baby's ways of telling us that he's not very happy. So looking at crying and looking at how we can help settle the baby with the parents. So this is a shared sense of questioning, curiosity. Oh, what does he really need? How can we support him? And looking at the baby's capacity for self-regulation. Well, does the NBO make a difference? We have a series of studies have come out and many more coming out that shows certainly it does contribute to the baby's ability to read and respond to the baby's needs and does enhance the relationship between parent and child. And even in Kashiwabara's study, specifically father and child, usually it's mother and child. And finally, we see that also it has helped us see it reduces postpartum symptoms. Now let's take a look at the NBO being conducted in a home visit setting. More and more, we recognise the importance of the home visit as a means of supporting families, particularly families who may be at risk. Here, Dr. Yvette Blanchard, a physical therapist, uses the NBO in her work in an early intervention setting. This family is living in transitional housing with a 5-week-old baby, Aisha.
Très mature, elle est capable de décider si c'est quelque chose qui est important pour elle ou pas. Et si elle veut dormir, elle est capable. Elle est capable, oui. On va la réveiller encore. Aucune réaction. Aucune réaction. Ah, un petit peu. Un petit mouvement des doigts. Elle bouge les yeux. Oh, un petit grognement. Elle essaie fort de se débarrasser de moi. Yeah. Nous, on ne pourrait pas, hein, les adultes, on se réveillerait tout de suite. Tout de suite. Le bébé, ils sont capables de protéger le sommeil. This family is from Haiti and are very much trying hard to fit in, to become part of this American society. But the ability to exchange in their own language made it for a much richer experience, because the reason why we do home visits in early intervention is the common point, the common focus is the baby. And we use the baby to engage with the family and in a way give them permission to tell us what they want to tell us about themselves and their infant. And we're hoping that babies' behaviors can at least be a way where we all feel comfortable about engaging. Et alors je vais la tirer assis. Oh, regardez-moi ça! Aïcha, elle est forte! Aïcha, tu lèves la tête! Tu lèves la tête! Oui, tu lèves la tête! Oh, regarde-moi! Allô! Allô! Comme tu es forte! Oh. Il faut protéger la tête du bébé, hein? Il ne faut pas nécessairement tirer le bébé comme ça, mais elle est forte. Elle est très forte. On va voir si elle peut protéger son nez pour respirer. Tu vois, je lui mets la tête, le nez dans les couvertures, et puis tout de suite, elle tourne la tête. Tout de suite, on peut à peine lui couvrir. Tout de suite, elle tourne la tête.
Afin de retrouver son respiration.
Exactement, pour dégager le nez, pour respirer. Mais on recommande quand même de ne pas coucher les bébés sur le ventre, parce que, est-ce que on vous a dit à l'hôpital de ne pas coucher Aïcha sur le ventre? Oui, parce que les bébés, des fois, en dormant, ne peuvent pas lever la tête. Mais on voit, elle commence à bouger les jambes. Well, I think what this does for me, it structures my observations. It gives me that vehicle that I need to put a baby through some mild or, mildly aversive sometimes procedures. It gives me the structure that I need to capture the behavioral competencies, and it's such a valuable tool. And the goal is not how well the baby does with pulling to sit, but it's how the baby handles it and what we can say about the baby throughout this home visit. Elle fait beaucoup de choses, hein? Oui. Il faut que je grandisse vite parce que j'ai un grand frère. Il faut que je grandisse vite parce que j'ai un grand frère qui veut mes jouets. Oui. Oh, là, elle ne veut plus tourner ailleurs. Maintenant, elle veut rester avec maman.
Et elle est capable, à son âge, de saisir exactement dans quelle direction telle ou telle personne l'appelle.
Elle sait où tourner d'après la source du son, de la voix.
C'est ça.
Mais les bébés, c'est pas croyable, ils sont déjà très compétents. Tellement de choses sont intelligents, hein? Oh, j'essaie de la tourner de l'autre côté. Elle ne veut pas. Elle veut regarder maman. Est-ce qu'elle peut voir une balle?
Oui.
Oui, regarde. Oh, mon Dieu, regarde.
Ouais, elle se promène les yeux.
Elle se promène les yeux. Tout autour, un grand cercle.
Yeah.
C'est difficile à faire. Aïcha. Et maman. Elle retrouve maman. Elle retrouve maman. Peut-être qu'elle va sourire, hein? Yeah. Aimez-vous cette évaluation?
Oh oui.
Ah oui.
Oui.
God bless.
Oh! Alors, vous saviez déjà beaucoup de choses, hein, à propos de Aïcha. Vous saviez qu'elle pouvait entendre et voir.
Oui, après un mois.
Après un mois, déjà, hein.
C'est une fille complète.
Oui, exactement. They already knew so much about this baby, and this baby was such a robust, what we call robust, mature baby. It was just an opportunity to wrap it up by confirming, I think, what this family already knew about their baby. And I think that for me, as an early intervention provider, it gives me more credibility with the family, that I can at least see what they see in their normal lives. And regardless of how sick a baby is or what type of children that we see in early intervention, we can always capture what it is that babies do and not focus on what babies don't do. So I think I think the parents, I left with them feeling proud, and I think that I'm hoping they'll look forward to seeing me again, so that we can share more about what their baby's developmental, road is along the way, and that we can guide them.
All parents of new babies need support as they begin to learn about their child. The NBO can help you build a strong relationship with families in your practice as you work together to learn who this new baby is and support the baby's ongoing growth and development. As you can see, the baby's behaviour is at the heart of the NBO, and helping parents read and respond to the baby's communication cues is central to the NBO. Using the NBO with infants and families requires training and practice. At NBO International, we've established training centres around the world to provide training and mentoring to practitioners from a wide range of disciplines. This training enables them to use the NBO in a way that's developmentally, theoretically sound, and at the same time culturally sensitive, so that the practitioners themselves in the work with families can provide the kind of support the families need in the respective cultural settings. Thank you very much for your interest in the NBO, and we look forward to working with you. I'd like to thank you very much for being part of this orientation program, and we look forward to working with you as you prepare to become certified in the Newborn Behavioural Observation System. In your next step, make sure to register for training at www.childrenshospital.org/Breslin Institute. Thank you very much indeed. Goodbye for now.